Christina. This is Al. He's been telling me for a decade that he's practically a doctor. So we decided to test that theory. Seriously, though, he is not a doctor. He's an idiot. And honestly, medicine is constantly changing, so I'm probably wrong too. The point is, this is not medical advice. Hello.
Good morning. What have we got?
How are you? I'm a 59-year-old male patient, the 98 kilos. He came in with a worsening dyspnea and cough. He's had anosmia, fever, fatigue, cough, and dyspnea for about 15 days now. Started getting worse out of nowhere. He's also complaining of some chest pain on the left side. No known allergies. Heart rate's 112. Rhythm is sinus tach. Blood pressure 95/66. Respiratory rate of 26. Tmax of 98.4. His O2 status sitting at 81. He is awake, alert, and oriented ×3. Pupils are equal and reactive. He is tachycardic. Pulses are +1s. You do hear S1, S2 heart sounds. There is some jugular vein distension noted. Delayed capillary refill of about 4 seconds. Seeing the chest pain is severe, sharp, and stabbing on the left side of his chest. From a respiratory standpoint, he's tachypnic, has tracheal deviation to the right, absent lung sounds on the left, diminished lung sounds on the right. Deferred his GIGU assessment for now. From a musculoskeletal integumentary standpoint, I've not noted any traumatic injuries. He's diaphoretic and a little pale. From an ID standpoint, we have consulted ID regarding COVID pneumonia because he did test positive for COVID a few days ago. Their recommendations are pending.
Yeah, that sounds like COVID.
Something like that.
We had low. You said we got low blood oxygen.
Yes.
Down in the 80s.
Yep.
Anosmia,
Yes.
which I learned at Scrubs means that you lost your sense of smell.
Excellent job, doctor.
Yes, that's where
I'm sure this will save the patient.
Yeah, absolutely. Now that I know what anosmia means. Nausmia. Anyway, all right. So we've got, but we're waiting on the COVID test.
No, the COVID test, he tested positive a few days ago. We did re-swab him today.
Okay, so he's got
So
COVID.
that's pending.
So that's
Yes.
the, how was his breathing?
He's breathing fast, a little bit of retractions.
Okay.
Definitely seems to be in some distress.
Okay, so let's get him on O2.
Okay.
And let's see, but we're also, you said the capillaries are taking 4 seconds to refill, right?
Yes. Yes.
So we're having some issues with blood not pumping hard enough. What was the blood pressure?
95/66.
That's probably low.
Yes, sir.
No, wait, that is low. I know what that is low. This guy's gonna be fine. He's not.
You
Let's
shouldn't
go.
doubt yourself like this. Come on, you're gonna get him one day.
Yeah, I mean, not this one, but one day, absolutely. So let's get him on O2. Let's put him on
Do you want a nasal cannula or non-rebreather?
nasal cannula.
Okay.
That's the one that goes up the nose, right?
Yep.
Ha! Watch out! I'm gonna save somebody.
Eventually.
Yeah, not this guy though. Let's see here. We need something to increase the blood pressure a little bit to get that getting into the. Yeah, because he's taking too long. So let's up the blood pressure with medication.
Okay, so some epinephrine or dopamine?
Let's go dopamine.
Okay.
Yeah, let's go dopamine. Okay. And then we need to get the breathing. We got the breathing. We got the thing. What was you said something with the heart sounds?
Yeah, you can hear normal heart sounds.
Okay. And you said the left side was?
He's complaining of severe, sharp stabbing chest pain.
Chest pain. Okay, so that also, all that suggests heart attack. Or at least some kind of heart issue too, right? Mm-hmm. So let's get him on a heart monitor.
EKG?
Yes, that's what I meant.
Okay.
Let's get him on.
I mean, I can put him on telemetry as well.
Yep, both of those. Absolutely do both of those. And what do we do for a heart attack? We monitor him very closely. Mm-hmm. And we need to what was his heartbeat? What was his heart rate?
Heart rate is 112.
At some point, I should really look up whether that's fast.
I really feel like they should have taught that in medical school.
I mean, maybe they did. I mean, who knows?
You were ditching that day.
I mean, there was a lot of other things to do. I'm a doctor. Not at that point, but still. So let's prepare in case he goes AFib.
Okay.
Let's prepare and make sure we have a crash cart nearby. And if it becomes necessary, do that thing where where you zap him to get the rhythm back regular again. Okay.
I'll put some pads on him.
Yeah,
so
exactly.
We've got the defibrillator ready to go.
That's exactly what I was talking about. Thank you for understanding. I know there's a lot of complicated medical jargon. Way to get through all of that. I really feel like you're gonna have a great career here.
Well, thanks.
Yeah, no, you're gonna be great. I think that's all right. So we had I was concerned left. Wasn't there something drooping somewhere?
No drooping. Tracheal deviation to the right and jugular vein distension.
That's in here.
Yes.
Right. Is he swallowing?
Yes.
He's able to swallow?
Yes.
And they said the breathing was clear.
On the right side. Absent on the left.
Oh, breathing's absent on the left?
Yes.
Oh, shit. He needs both of the lungs, though.
That is usually helpful, yes.
Okay. All right. So then let's also fix his lung.
You want me to consult surgery, or...
Let's see. How would I fix a lung?
Push some more air in.
Let's see. I think his lung collapsed, right? So if the lung collapsed, you get it back by... I mean, I want to blow it up like a balloon, right? Just put air pressure down there and let it pop it back up. But I feel like that's going to go terribly if you actually try to do that. Have we tried just opening his mouth and breathing really hard? Just a...
I have not.
No?
I'm happy to give him some mouth-to-mouth, though, if you'd like.
No.
I can try it. I'd prefer to use a bag. Can I, bag him, maybe?
I guess. Let's hold off. We're going to leave. I'm sure if we get the oxygen thing and we do all the other stuff, and then let's consult surgery for the lung, and I'm going to pretend like that's not going to be what kills him.
Okay.
Great.
Great.
And notify next of kin.
Definitely.
All right, I think that's it.
I think so.
Next patient.
I'm so sorry, doctor. I have to report that your patient has died.
I'm not a doctor anymore. Nope, don't. You need to take that up with the other guy. Sorry. This is not my fault, but I honestly this is yet another time where I'm like, maybe I can not completely kill. No, I didn't.
I almost thought you might get this one with first aid training.
Well, because he did.
And then I immediately was like, nah.
So what killed him?
So this is a case of tension pneumothorax.
Oh yeah, no, obviously they covered that in first aid.
Secondary to a bleb caused by COVID pneumonia. So I threw the COVID part in there because that can, in 1% of people, is a very rare complication, cause blebs.
What the hell is a bleb?
So sometimes when the lung tissue is damaged, or just depending on issues with the lung tissue, the alveoli in your lungs can rupture.
The little tiny parts at the end? A
piece of it becomes distended, and it creates what's called a bleb, this abnormal...
Wait, time out. The air... You didn't say what I was about to say. What did you say was the part of the lung?
The alveoli.
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 Not what I was about to say. Alveoli. Okay. Is that the little bubble at the end?
Yes. So your lungs look like a bunch of little grapes at the ends, and that's where the air comes in at the end and gets close to the capillaries so that it can transfer oxygen.
The osmosis and all that shit, right? Okay. So that went...
Yep.
Okay.
And then, because the tissue is damaged, it leaks air into the pleural space, which is the tissue surrounding the lung. And then that air collects and causes the lung to collapse and air to collect inside the pleura.
That's bad.
Yes. It's fine. Some patients are asymptomatic and they find this on an x-ray and they're like, oh, hey, we should take care of that. However, if you have a tension pneumothorax, it means that air has developed to a point that it is causing tension inside of your chest.
Which is where the pain was coming
inside
from.
of your thorax. Which is why there's pain, and also tracheal deviation. The trachea is being pushed this way.
Because the lungs are all...
Because on the left side, there was air pushing.
What part of first aid did you think was going to help me with this?
I don't know.
All right.
They teach it in the ER because it's like a medical emergency that has to be dealt with right away.
I think you may have vastly overestimated what they teach us in first aid.
True. Which is why I immediately went, nah.
No.
So the jugular vein distension, because there's pressure, the blood cannot flow back down into the lungs from the head. So it's
just shoving that over there, so this can't go where it needs to go.
There's high pressure, so your jugular veins become very distended, they become very visible. And your trachea goes the opposite way of where the air is. So if it was on the right side, it would go to the left. So you can know which side it's on.
Okay.
Some ways you can find this. CT, chest x-ray, or ultrasound. However, all of those are going to cause significant delays for your patient and could kill them. Because a tension pneumothorax means that your patient is having hemodynamic instability. So your low blood pressure, your high heart rate, because now the heart can't fill very well, so it's having to beat faster because it can't fill because of all this pressure.
What's a normal fucking heart rate for an adult?
60 to 100.
60 to 100?
Yes.
Okay. I refuse. I want everyone else to know. I very much refuse to look up any of this stuff afterward. I'm not going to, because to me it's cheating if I go look up a bunch of stuff. So I don't look at the cases beforehand, and even though I should always know what a normal heart rate is, I never look at it. I refuse to if I can't remember it while we're doing this.
He also won't remember next time.
I also will still forget and probably ask you tomorrow. Okay, so 60 to 100. He was at
112.
112?
So not terribly high, but high.
Right.
But you also have a low blood pressure because the heart's having trouble filling because of all this pressure, so it's doing this.
Yep.
Raising the heart rate and lowering your blood pressure because you have poor cardiac output because everything's being pushed this way.
So the meds didn't help.
So the meds are not going to help. Not a terrible thought. We need to raise the blood pressure. You're also going to probably raise your heart rate with this. But you have to relieve that tension or you're just giving dopamine, which is going to raise your heart rate and give you less cardiac output.
So what was I supposed to do?
Needle decompression, immediate needle decompression or chest tube insertion. Because you need a way for that air to come out so that you relieve the pressure and it re-expands. And then
God damn it,
everything fixes itself.
I'm sorry, let me be real clear here. The solution to this was to pop a hole in the guy and let the air out?
Part of me was really hoping that you would try to intubate this patient.
No, I knew it.
Because you kept saying, blow it up like a balloon. Any kind of positive pressure, because you have this leaking air into the pleural space, the more
it's going to make it worse.
Air you push in, the worse it's going to get.
I'm just really annoyed that the solution was just to pop a hole in the guy and
let the air out. Because the air is in the wrong spot. So, really, ideally, there are images of tension pneumothorax on the internet, and it's always listed as the x-ray you never want to get. Because this is a clinical diagnosis. If you see this happening, you need rapid treatment.
So by the time you see
the
X-ray,
you're waiting on x-ray and waiting to see it, you're like, shit! Sorry.
It's fine.
Yes, a chest tube insertion is usually the best option because you can continue to relieve that air until the lung can heal.
A chest tube insertion?
Yes.
So instead of just popping it, you leave a hole in there.
You leave a tube in there to hook to suction or water seal so that air can't get back in through that tube. And it relieves it. You also, with pneumothorax, you want to put your chest tube higher up because air goes up, fluid comes down. So you don't want to put your chest tube way down here because the air will be trapped.
Yeah, because that'd be the problem I made. Okay.
Location.
Okay.
So you did really well. This patient is going to need oxygen therapy while they're healing from this bleb, also from the COVID piece. If they have recurrent pneumothorax issues, pneumothoraces, thank you, that word was escaping me for a little bit, which in about 30 to 60% of patients, it will recur. Then they may need surgical intervention for them to do like a chemical pleurodesis, meaning they go and like seal up the pleural space there so that it will stop leaking.
Okay.
So consulting for surgery and putting the patient on oxygen were two very good interventions that you had.
See?
He's still done. But
I mean,
good
yeah.
thought.
But that was something. Okay.
Yep.
All right. Anything else? I mean, I killed him pretty thoroughly.
I mean, you killed him real good.
Real good.
Putting him on telemetry was good, but yeah, he's dead.
I'll get the next
Pop him
one.
with a needle.
I'm so pissed. Because that's the kind of stupid that I would absolutely go for. And I was like, no, come on, take it seriously. You could do this. And I should have just gone with my first idiot thought because it would have been good. So how do you fix the little pop balloons? Is that surgery?
Eventually the body will heal. And actually a lot of these COVID patients there are COVID patients that have had no pulmonary history, like no issues from a pulmonary standpoint. A few of them have been smokers, but that have developed these blebs that just spontaneously happen and they end up with a pneumothorax. However, those patients tend to, when you put in a chest tube, it's allowed to heal. They tend to do okay. As long as the rest of COVID doesn't happen.
Right. Okay.
So.
All right, folks. Well, that's it. Let us know in the comments what we missed. As a reminder, cannot emphasize this enough, not medical advice. You'll find links, right?
You will find links. So if you want actual reliable information, please check the links under the YouTube channel.
And if you've got any cases you think we should look at or anything else like that, please send it to us. Let us know. And I think, are we good?
Yeah.
We good? All right. Thanks. Until next time. Thanks, everybody.